Welcome to our health policy seminar today. We're going to be talking about policies to support the healthcare workforce. And I'm delighted to have with us on our panel today, Sarah Markowitz, who is the Winship Distinguished Research Professor of Economics at Emory University. We have Cynthia Lawrence, who's Director of the Office of Workforce Development at Carilion Clinic. Welcome to both of you. We also have Hannah Maxey, who is the director of the Bowen Center for Health Workforce Research and Policy at Indiana University. And we have Megan Healy, who is the former Virginia Secretary of Labor under Governor Northam. Welcome, panelists. Thank you for joining us. We're going to start off today with some remarks. Sarah, if you would touch us off, please.
Okay. Hang on, Allison, I'm getting a message saying I can't screen share while someone else is.
Okay.
Okay, hold on. I think I got it now.
Excellent. There you go.
Okay.
That looks great.
Good. Great. Thank you. So hi, welcome. I'm a research professor, and I've been doing a lot of work about scope of practice laws and the NP workforce. So that's what my presentation is going to be about today. For those of you who don't know, scope of practice laws are the legal authority given to licensed healthcare providers to provide medical services. So basically, in the context of nurses, what they do is they define the roles that these nurses can take in their practices. And in particular, in some states, these laws articulate oversight requirements by physicians. These laws take care of both practice and prescriptive authorities. I'm going to be talking to you today about nurse practitioners, but in general, these laws actually cover a whole host of advanced practice providers that I have listed on the screen here. So these laws actually have wide reaches. Just to give you a kind of a sense of the numbers that we're talking about, this is just recent occupation employment data from 2020, the last year it was available from the BLS. And so you can see the nurses, the APRNs we're talking about here, about 271,000 nurses. So the physicians and surgeons far outshadow them, but it's not an insignificant part of the workforce. Just to kind of get everybody on the same page here, what I'm talking about today are the advanced practice registered nurses, which includes nurse practitioners and some specialists. I'm not going to be focusing on the generalist nurses, the registered nurses, and the licensed practical nurses. Their numbers far exceed anything that we see for the APRNs, and of course they're important, but they're governed by very different scope of practice laws than the advanced practice nurses. Okay, so more specific about these laws, we categorize the laws into two general categories, the practice authority and the prescription authority. Okay? So the practice authority really dictates whether or not physician supervision is required. And within these state laws, some states are going to have physician supervision and some states are not. And then within the document about supervision, there are requirements for collaborative practice agreements, which is basically a contract between the physician and the nurse. And in some states, those collaborative practice requirements have protocols, which specifically outline what a nurse can and can't do. For example, what types of drugs he or she can prescribe. In other states, they have no specific requirements for this practice authority. A similar mechanism happens under prescription authority, which types of drugs are allowed, if any, and if there's physician oversight for prescription authority. So some states may have what we call independence in practice authority, but not in prescription authority. Okay, well, right now, the policy movement here is for what we call full practice authority, which essentially allows the APRNs to practice to the full extent of their training without any physician oversight requirements. So this map actually just shows you kind of where the landscape throughout the United States right now. So you can see in the dark blue, these are the states that have this full practice authority, which means the nurses are free to practice up to the level of their training, up to their certifications. The light gray are states that require physician oversight of nurses, and then we've got 2 states that we're waiting for those laws to become effective. Just to give you a little more concrete example, this is what the law looks like in Wyoming. It basically just says that APRNs are directly responsible for their patients and they can prescribe drugs. And since this is sponsored by George Mason, I pulled up Virginia's law. So this full practice authority for nurses was granted in April of 2018, although newer nurses have to work under or within a patient care team. And so you can see this is not quite as direct as the Wyoming law, but basically it says that the nurses can still practice, but they need to consult and collaborate, which is the norm for nurses. Okay, and then in terms of the prescription authority, right now the nurses in Virginia can prescribe Schedule 2 through Schedule 6 controlled substances, and that was phased in, as you can see from the chart here. Okay, what's interesting though is that the Board of Medicine does have some say over the prescriptive authority of nurses. And then where I live in Georgia, we don't have full practice authority. We have a very restrictive environment here where our nurses have to practice under a collaborative practice agreement supervised by physicians with a protocol. And so you can see on this slide the type of things that are required by law. One really interesting one, I think, is that this 4th bullet here, where the patient who receives a prescription drug for controlled substances have to be evaluated by a physician, at least on a quarterly basis. So that can create some redundancy here. Okay, these laws are actually quite controversial. There's frequent legislative battles. Basically, the critics argue that these oversight requirements are protect the public health, they protect patients. The proponents argue that the NPs are, they can provide high quality care at a lower cost and greater access. So this is kind of what my research agenda has been, is trying to tease out whether the transition to these full practice authority laws, do indeed protect the public health, or whether there are, no effects, higher effects among quality care, and of course the labor market, which is what I'm going to briefly talk to you about today. So that's just what this slide says. Okay, so just in thinking about how these oversight laws can affect the day-to-day practice, this slide just talks about when there is these oversight and these collaborative practice agreements, you can have some inefficiencies, right? You can have additional documentation required, you can get delays in care. There's barriers to the new practice, and this directly speaks to the labor market, where you have to find the physician to enter into the collaborative practice agreement with. And then if a physician exits, you can also have interruption in the NP employment. Talking a little bit more in detail about these collaborative practice agreements, these are just some numbers for you from a fairly recent article, where you can see that not all APRNs have to pay for these collaborative practice agreements, but 22% actually do. And so this is money going directly to the supervising physician, with the median fee at $650 a month, and then a maintenance fee of $500 a month. So these are not costless. And then this was another source talking about Florida, which now has full practice authority, but when they did have their collaborative practice agreement, again, you can see the numbers here. For self-pay nurse or self-employed nurses, they had to pay, 50% of them had to pay for a collaborative practice agreement. And we're talking, an average of over $1,000 per month. Okay. I'm going to skip that slide. Okay, so when we talk about how these policies can affect individual labor supply decisions, this kind of gets at the heart of it. Okay, so there's these search costs that we're going to start with, where you've got, from a nurse perspective, the time and money cost to find a physician who's willing to enter into the practice agreement. And so from a labor market perspective, this is going to affect a nurse's decision to work, maybe their decision to migrate, meaning, they might move, or not move depending upon the practice environment across state lines. And it could promote job lock, right? If it's expensive to find a new practitioner or a new physician, you just may not want to move. Okay. I've talked about the monetary costs. So from an economics perspective and labor decision, we say that this is going to affect their income availability for other activities, and that affects their decision to work and specifically work hours. Okay. Economists always talk about utility, which is our way of just saying happiness. And so this third line here talks about the psychic cost and benefits. Some nurses may hate working under oversight and some may love it. And so I'm not going to say which one is which, but basically it can also affect the work hours, decision to work, and the decision to migrate. And then lastly, we have compliance costs, which is lost time from consulting with physicians or obtaining approvals. And this affects marginal productivity and can affect wage rates. So these are the predictions that come out of labor theory, just that if we have states that switch from some kind of oversight to a full practice authority, we might expect to see increased labor force participation, migration to more favorable practice environments, more self-employment, and it actually predicts an indeterminate effect of work hours. Then we need to think about the market level. So how does this affect the big supply and demand and the overall healthcare market? And this is actually a very open question still. In terms of the marginal productivity, how productive are these nurses? As I've said, some of this can generate these unproductive administrative burdens, which can affect the productivity of both the physicians and the nurses. We have issues about substitutability between workers. And then from the demand side, if you have fully authorized or this full practice authority, this may actually encourage the opening of new healthcare facilities. That is, owners may want to staff retail clinics with nurses. Okay, so what does the academic research show? There's been quite a few studies on labor market outcomes, including my own, and this is what we find. So if you look at the effect of this full practice authority, no oversight on these individual outcomes, we do see a small increase in hours worked by NPs. In one of my studies, don't find any change in the probability of part-time work or in the probability of working versus not working. And a bunch of studies also find no effect on hourly wages. In terms of self-employment, this is actually where the biggest effect comes in. We find a much higher probability of self-employment in states that have transitioned to this full practice authority. It's nearly a doubling of the rate. Okay, and there's also been some work about where they work, and so it looks like the ambulatory care setting increases with this full practice authority. Location of migration. So this, again, what the academic research shows is that a little bit not as big as the self-employment, but we do find some movement. Some nurses are moving to get controlled substance prescription authority. They like to stay where there's full practice authority. And there's commuting to a less restrictive state. So when states are thinking about should they pass this law or not, they might want to consider what the border states are doing. And then in terms of the market level data, these are much harder to quantify. There's some problems with some of the data that's being used. But basically right now, the results are a little inconclusive. So the first bullet has two studies that showed on the aggregate, where you have states with this full practice authority, you get greater numbers of NPs, so county level counts of NPs per capita. But using the exact same source, another study found no effects. So the jury's still out on that one a little bit. Okay, so overall, this is what we can say about labor market effects. Small increases in hours worked, large increases in self-employment, and some locational preferences. In case you're wondering what we find for health outcomes, other researchers have looked at these, and basically what they find is either no difference in health outcomes, with the degree of restrictiveness of the laws, that is, whether there's supervision or not. And in some cases, we do get some improvements of health. But really the message here is that we don't see any harm to patients from transitioning to this full practice authority. We do see some increases in utilization and in access, but it's going to depend upon what measure you're using. And so this slide just highlights the specific things we find that increase with full practice authority and things that you find no effects of. We do find a little bit on prices, so that we do find it's cheaper in states where NPs have the full practice authority. And the reason for that is probably just because of Medicare fee schedule, where right now nurse practitioners are getting paid at 85% of the physicians. And you can see some of the other nurses here are getting a little bit more. And lastly, talk about total healthcare expenditures. Well, what happens if we have prices falling and utilization rising? Of course, those offsetting things make it hard to predict. But there's been these couple estimates from 2 studies. So one of them, this top bullet here, basically found a savings about $543 million in emergency use for ambulatory care sensitive conditions. So that was actually a very well done study, high quality study. And in my own work on C-sections, we found a savings in using CNMs as a reduction for C-sections. Okay, so just to wrap up and summarize, these laws are far-reaching. They affect not only nurses, but a bunch of other advanced practice practitioners. Right now, the evidence shows that transitioning to this full practice authority for the NPs does not disrupt labor markets. We see more self-employment. We have no harm to health, and there's some evidence of lower healthcare prices. So if you're looking for a policy, that may be one place you want to go to make these labor markets more efficient.
Thank you so much for that overview, Sarah. I really appreciate it. Cynthia, we're going to turn to you next. Carilion straddles Virginia, which has the full practice authority, and Tennessee, which does not. How does Carilion, and how do you think about workforce development in your health system and your position?
Well, thank you for having me. Let me start by sharing my screen and get all those mechanics out of the way here. Okay. Well, thank you, Allison. Let me set the context for what I'm going to go over in terms of workforce development in the health and life science sector by going back to the geography that you just mentioned. Carilion Clinic is an acute care and ambulatory care health system that is the largest private employer west of Charlottesville in Virginia. We serve a population of approximately 1 million people, and our operation is about 100 years old, just a little over 100 years old. So we are well entrenched in the community and have a strong commitment to the not only the health of the community, but the economic vitality of this part of the Commonwealth. My role within Carilion is a new role in terms of standing up an Office of Workforce Development. And I do not come from the healthcare sector, so I want to set that context as well. So I am an entrepreneur by background. This is my second career as of a few years ago, entering into this, and the approach that our region has taken to help grow the health and life science workforce is one of collaboration. Our region, from an economic development perspective, very often has to collaborate between and among municipalities and organizations to get things done. And that's just kind of a standard operating procedure for us. And so when we started to contemplate the need for a unique approach to developing this workforce sector, it was a natural evolution to thought that we would just approach it in the same way that we do many other things. I also want to set a geographic context for some of my remarks by describing for the audience, and I don't know how far reaching the audience is, but Virginia has, the administration of Virginia several years ago defined some geographic boundaries that are clustered by industry sectors. There are 9 regions, and they are numbered 1 through 9, and they are called growth and opportunity regions, and short is GO Virginia. So we are in a GO Virginia region that is number 2. And our geography is defined, some of our geography covers Carillion service territory, some does not. The geography runs from Lynchburg, Virginia, sort of west and down the Interstate 81 corridor to Pulaski and Giles. And then from the north boundary, Allegheny and Craig to the West Virginia border, down to Franklin County, which borders more of the Southern Virginia area. Those are defined by the state, as I said, according to economic sectors. So we have a unique challenge in our region in that we are serving a population that transcends the actual geography that I'm going to talk about, but that's all good because it goes right into our collaboration approach. So with that context, let me move into, and I'm now trying to move my thing forward here. There we go. I'll move into what we're doing now. This is this approach to our needs in the health and life science sector is obviously a very complex problem. We need to have a short-term solution while we are developing a longer-term strategy to develop a pipeline. We often call this building the plane while we're flying it, but we're doing a pretty good job with that as we're still in the air. Education and training is complex and expensive. We know that. And so we are pulling together resources that are already in existence and sharing those resources. We're looking at gaps, we're looking at duplications, and we're coming up with solutions that work around all of those parameters. And of course, as I said, we believe that this is very important for our economic development in general. So let me introduce a term to you. I just used the word pipeline, but I want to correct myself and say we are terming the traditional talent development approach a highway. And the reason that we zero in on the word highway is that, as you just heard, the licensure and the development and education of the workforce is complex, and it's long, and it can take meandering turns, and sometimes life happens. People get on and off the highway based on certain phases of life or family demands. And we just find that to be a more compatible term with really the reality of how to develop a career in the health and life sciences. So I'm introducing this to you, and I also want to draw your attention to the Claude Moore Foundation, Claude Moore Scholars. You'll hear from Dr. Healy at the end of this, she is affiliated currently with the Claude Moore Foundation, helping to develop this highway approach across the Commonwealth. And that is a philanthropic organization dedicated to the K-12 programming in the health sciences to help our young people take a look at this as a career opportunity. So our approach, 2.5 years ago, a group of civic leaders in education, the health sector, and the municipality economic development arena came together to agree that we needed a collaborative approach to workforce development in the health and life science industry. And we formed a coalition called the Blue Ridge Partnership for Health Science Careers. this is the list of stakeholders that are in the organization involved. And so back to the geography, there are 17 school districts in the Go Virginia geography I described. We have a cluster of original stakeholder districts who raised their hand despite the shutdown of the pandemic in 2020 and said, we're going to go ahead with this and work through it remotely or however we're going to deliver education, we're going to work through it. We have 4 community colleges involved in this geography. We have 5 four-year institutions, 3 postgraduate institutions, and we have 9 stakeholder employers, one of whom is a foundation that is a part of a credit union, Freedom First Credit Union. Their foundation is Freedom First Enterprises. They have a mission in our area for workforce development and economic vitality. And so they have agreed to partner with us, and they are now serving as our fiduciary agent for the organization. We've organized ourselves somewhat like a small company. We've got an executive board, a committee with representation from all of those stakeholder groups. We have some support staff that very, very streamlined support staff that are in-kind contributions by our employer stakeholders serving to help coordinate the activities. We have 5 task forces illustrated here, different focus areas with members that come from all of the stakeholder groups. We have a finance subcommittee that is a standing committee of the executive committee. Carilion Clinic has contributed a person on a part-time basis from their enterprise project management office who's providing some support. We do have some Go Virginia funding. There is some state funding. It's a competitive grant process. We have some funding there to help us with our data collection and some of the other administrative support work that's required to know how we're doing. And then each of these task forces operate under a charter. And we have also developed some logic models for each of them. Those documentations will serve as the foundation for ultimately a blueprint document that we're planning to have ready this fall. Our hope for that blueprint document would be that it would be a how-to guide for any other region that would like to implement this approach to their workforce development. Funding I mentioned, and I'll just briefly go over this. The entity itself is not an organized legal entity. A caveat to that, we have found that 2 years in, we're going to have to start signing a few contracts or grant applications. And so we are going to set up a 501c4 entity, and that is a learning point along the way here. The 501c4 designation allows us to advocate or lobby to help influence policy, and that's very important here in this sector. We have some state funding coming through that goes directly to the community college system to cover dual enrollment for health science students that are dual enrolled through the high schools. We do have some funding from the Claude Moore Foundation philanthropy that covers things that state money does not cover and helps stand up new programs at the high school level. And then I mentioned the Go Virginia funding that we are using. The executive committee, this is a slide just for illustration showing you the members of the executive committee and the coverage. And we do have advisors to the committee that help the committee stay focused on the big picture, long term, from all of the key stakeholders that are involved. There are about 100 people that support that organizational chart that I showed you. This simply shows you the breakdown, who the chairs are, and that they are very active in a reporting process, a meeting cadence, and are really producing some great work.
Terrific.
I
need you to kind of, we want to be sure we get to, yep.
Okay.
That would be great.
Right.
That way we'll have time for Q&A. We've got some good questions.
Absolutely.
Mm-hmm.
So what I wanted to tell you, I think one of the most valuable things that has come out of all of this work is the list of the most critically needed jobs in our area as defined by the employers. So this is boots on the ground data that is collected through surveys and face-to-face interviews. And we have prioritized these jobs by time frame. And that is keeping us focused on how we're going about our work. So I'll stop right there, and Allison, let you cue it back to me if I can answer any questions.
Absolutely. Thank you so much. And so we'd like to bring in our next panelist. We have another policy researcher giving us an overview of, besides scope of practice and the kinds of collaborations that Cynthia is building in her region, what other kinds of policy tools do we have available to us, Hannah?
Sorry, had to unmute. Can you all hear me now?
Yes, absolutely.
Great, wonderful. Very excited to be here with you today. And actually, I'm really glad I got to go third, because a lot of what I'll be talking about intersects with and complements very well what we've heard from Sarah and Cynthia previously. I'm gonna actually take us up a level and talk about building a state toolbox for health workforce policy. So I think that I need to begin very quickly with level setting on why states need a toolbox. And although we're all familiar with and hearing in the popular media now about health workforce shortages and crises and burnouts, quite frankly, this is nothing new. We were having challenges with our healthcare workforce here in the United States for years and perhaps decades within some professions among our healthcare careers and occupations. Really, it's just that these challenges have reached a magnitude where they're starting to impact the general population, not just underserved populations or those in rural communities or those with special healthcare needs. Workforce shortages have predated the COVID pandemic. Obviously, I think most of us today are very familiar with the discussions regarding rural workforce shortages. Behavioral health workforce shortages are also a notable challenge. These definitely predated and have just simply been exacerbated by the COVID-19 pandemic. When we look at some of the other challenges that we're facing here in the United States and within states, we see competition for workers, and especially more entry-level healthcare careers and roles is really impacting the health sector to a greater extent than it has before. For example, when Amazon's average national hourly wage is $16 an hour plus health benefits, or Uber drivers who can set their own schedules are making an average of $18 per hour, it's difficult for us nationally to recruit people into direct care jobs, which are extremely challenging and physically demanding, for $14 an hour. And in some states, we're looking at $10 an hour for those types of jobs. We've heard a lot about workforce burnout. So I think we're all familiar with the pictures, and it is horrific, of our nurses, our physicians, our frontline workers, just quite frankly, completely burned out and exhausted from caring for the population through the pandemic. Burnout is not new. AHRQ was studying this all the way back in 2001. They were already studying physician burnout and putting reports out. In fact, there was a large report that they issued in 2017. So although we're hearing a lot about burnout, this has been an epidemic of burnout in our healthcare workforce and among our providers. So these are challenges that are not new. I guess the last that I'll bring up is student loan debt. Those of you that are students on the line today, our health profession students, which include, I think, public health professionals as well, and those that go into health administration, I include that all within health professionals. They are coming out with some of the highest levels of debt. And when we are looking at those top tier levels of debt, we see dentistry, medical specialties are among the top. So healthcare occupations and the graduates from those programs are coming out with high loads of debt. It's important for all of us to be aware of and understand these challenges and to take action among them. I think what I'd like to share the rest of my time with you all today is the role of states and the role states can have in health workforce policy and planning. We already heard from Sarah about how states regulate scope of practice for health professionals. But in addition to regulations, even outside of scope of practice, states have influence on other types of policies and factors that create the environment in which our healthcare is delivered and the environment in which our healthcare professionals practice. States are responsible for identifying where their workforce shortages are. They're responsible for developing funding or allocating federal funding to workforce development and investment programs. And of course, states develop and oversee their Medicaid programs, which provide funding to and reimbursement to healthcare professionals for the services they provide to the most vulnerable among us. So the bottom line is state health workforce policies are critical to addressing many of these challenges that we're facing today. So it's important for states to develop strategies, or what I'm going to say, have a toolbox on hand from which they can build and have resources or strategies to pull to help them in their health workforce policy and planning. And I want to talk about three tools in the toolbox, or three areas where states can have tools. The first is information. So we have all heard the phrase knowledge is power in relation to education, but I think in relation to health policy, information empowers. And so in relation to state health workforce policy, information on the workforce is needed to quantify and understand issues, and ultimately to have objectify potentially contentious discussions, as can be the case with scope of practice policy discussions. When we think of health workforce information, we typically think of supply, demand data, labor projections, but these type of data can also include more qualitative information, such as workforce burnout factors. It can even contain information such as barriers to Medicaid participation or barriers to medication-assisted treatment participation within their community. In addition to information, I want to talk a little bit about engagement as a tool. There's also a well-known African proverb that says something like, if you want to go quickly, you go alone. If you want to go far, you go together. In most cases, no individual or group has all of the knowledge, context, or perspective to address our complex health workforce challenges. Engaging diverse and broad stakeholders that represent all of the various perspectives that are needed to do solution and good policy development is critical to ensure that when states are looking at and pulling their policy levers, they've thought through every angle, and that they have already got buy-in and consensus that will help with the implementation of those policy strategies. The final tool are actions. And I like to think of these as the policy levers that states can pull to empower or help to address their health workforce challenges. So some of these, they can be legislation, it can be rules and regulations, it might be state appropriations, it might be state programming, educational policies, etc. But those are all actions or potential actions where the state can pull levers to realign their healthcare workforce policy environment. States that are intentional and have provisions or strategies in place for each of these areas are better positioned to address their health workforce challenges. So let's talk about getting tools in the state toolbox. So we talked about information, and I have a list here. I think you guys are going to be sent the slides after. I'm not going to go through all of these, but there are numerous state level sources that states likely already have that they can take inventory of. They may already have inventoried and identify and get into a place where they can quickly pull the information to inform policy discussions or evaluate key policies. This is just a list. I've organized it where the blue colored are individual level data and the red are typically more aggregated data. So some examples of state level data sources: licensure. Now, I know that not all health occupations are regulated by states, but many are. In fact, we talked about scope of practice and nursing. When we're talking about clinical counselors, behavioral health therapists, we're talking about state regulated workforces. State licensure is a source of data. There are a lot of limitations to it though. Your license address may not be where you practice. You may hold licenses in 2, 3, or 4 states and really only practice in one, but you're keeping those licenses in case you ever want to use them in the future. The proliferation of interstate licensure compacts for healthcare professionals and the adoption of those compacts across the states is changing the game in healthcare workforce. And it means that if the compact is implemented with a multi-state license, where a professional has one golden ticket multi-state license that allows them to practice in every participating state, state licensure may have limitations. They may not actually hold a single state license in all of those states. Various other strategies, I could go on for an hour about that, I'm not going to. But in addition to the state level data sources, there are also national, publicly available for the most part, state level data. And so I have a list here for you all. Happy to follow up with those of you that have questions or want to know about these data sources. We don't have time to go into it today, but these are some sources of information that if you're looking for, hey, how can I understand or get data to quantify these issues within my state? These are some opportunities for states, tools in their tool belt that they can use to quantify those. The next tool is stakeholder engagement. Information, data alone is not enough. I'm a researcher, so the more data, the better. But the problem is we have to fully understand the data and the context, okay? Information alone is not enough to understand the complexity of health workforce challenges and innovate the solutions that we need. Stakeholder engagement, those broad perspectives are absolutely critical to provide the context of those conversations. Stakeholder engagement at the state level can be formal or informal, but it definitely should include both government and non-government stakeholders. So that means different agencies within state government, maybe your governor's office, maybe your General Assembly members, but also employers and professionals themselves. I see you're off mute, Allison. Am I over time?
Yep, if we can move to the state policies, and we will certainly have time for Megan and our Q&A. Thank you.
Absolutely. So the last tool that I'll talk about are the levers for action. And just very quickly, so we already heard from Sarah about scope of practice. There are various other regulatory policies, however, that states can examine and look at pulling levers on. I already talked very briefly about Medicaid policy being a lever that states can use and that directly influence the health workforce. And then we heard about state appropriations from Cynthia and how state appropriations are used to support the work that they're doing. And finally, of course, the education pipeline or highway, whatever we want to call it, states have a role in making decisions about the appropriations for those, and in some instances for our public institutions about class sizes and where allocation should go to increase the workforce. I'll hand it back over to you, Allison.
Terrific. Thank you so much for your comments. And Megan, we could turn to you from your perspective in your role that you had at the state level. Tell us what your priorities were in terms of workforce development and some of the key challenges that you face.
Sure. Well, thank you so much for having me today. And it was great, the speakers. A lot of what I was to talk about, Hannah covered, so that's great. I also want to thank Cynthia for her hard work. If I could take Cynthia and replicate her all around the state, we would not have any workforce challenges. We'd be perfectly fine. We'd solve all the problems. And I've had to even talked about her, how we can clone her. So, it was in 2019, I was a co-chair with the Virginia Healthcare and Hospital and Healthcare Association on a workforce advisory group for the state. In 2020, in March, that council shifted to a lot of other things that are needed, especially of staffing challenges during the pandemic. And some of the hardest parts is, even though I was Secretary of Labor for Virginia, I worked very closely, of course, with the pandemic, of really looking at the challenges of the workforce, looking at executive orders that we can do to expand scope of practice, thinking about the compacts of the states and utilizing other folks from other states through reciprocity, as well as I worked with our Medical Reserve Corps, which we grew from 8,000 participants, over 36,000, to get them out for vaccination clinics, testing centers, contact tracing that we did. So I worked very, very closely with the health systems over these past couple of years to really think about workforce challenges. And we had challenges before. I think everyone said that. I also have an identical twin sister who is a senior executive at a large health system. I think they have 13 hospitals. So she used to tell me also every single day about not finding workforce. And so it was definitely a priority in my position. The ways I always think about it, just to make it simple for me, is I always think of 3 different buckets that we'd work on. Even easier, they all start with the word letter R. So the first one is kind of we went over as routes, like how do we get into the healthcare workforce, the education pathways. Some of the things that I want to add to the conversation, the great work we talked about the community colleges, starting early in high schools, working with our university systems. In Virginia that we've done is apprenticeships is something. So we know if we're going to pull people off the side to move into healthcare on day one, they need a paycheck, right? They need to feed their family, pay the bills. And so apprenticeships is something that we're expanding in Virginia for sonography, EMS, EMT, CNA is something. So I know other states have done this very well, certified nursing assistants, but Virginia is really getting into this area because if we're going to entice somebody, education, as we know, is expensive and it's hard, especially if we're looking for swirling individuals. Our sweet spot on our short-term credentials in Virginia is around 36, right? So they've been struggling in and out of different careers, but trying to put them on that path is important. Building better awareness around these healthcare jobs. They are tough, exactly what we heard, especially the wages. I always use Walgreens, pay $17 an hour. Some of my worst days as secretary, it was always Saturday mornings, right? When you think you made it through the week, you finally at 5 o'clock on Friday, you didn't get that something's on fire call. It was Saturday morning in long-term care facilities that the staff didn't show up, right? And I don't blame them. I was a secretary and their jobs at the level at long-term care during COVID was 100 times harder than my job ever was. And there's lots of lines I didn't have, but I did not have to deal with some of the issues. And we know it's because of wages, the quality of life, but we know this, we need those people on the front line. And so really thinking about what that looks like, that pathway, those routes. Loan forgiveness is something we did with physicians in Virginia. We're looking at even doing it at the CNA level and the nursing level and all levels of education to pay back loans. Another thing we're looking at is our immigrant and refugee population. That wasn't mentioned earlier, but we have 2,000 Virginians that have some type of medical licensure in their native country. And how does that translate? I mean, a doctor somewhere might not be a doctor here. Obviously, there's a long path, but why can't we get them in a hospital treating patients with care? And so we're looking at that. We've also, about 10% of Virginia's population is veterans. So we've done a lot of crosswalks with our military and specifically developed our military medic and corpsman program. And so we take anyone who's exiting with some type of medical background. They can do surgery on a drill field, but they can't do it. They can't fold sheets in our hospitals. And so we're sticking them in our facilities. I love it. We have about 40 of them in our public behavioral health institute working, and they're developing skills. We have mentors that are checking off that their skill sets, and then they're sitting for licensure exams, look at those career pathways. We've also this past year for community colleges made it more affordable. We have our G3 program, and about 12,000 of those individuals are in healthcare. The second are, we have routes as resources. We heard about Medicaid reimbursement, wages. I think that's our number one issue, along with just the culture and some of the quality of life of some of these healthcare. So we know Croydon Clinic, I think are doing a lot of great support, wraparound for retention strategies. Wellness is providing extra care to their workers is really, really important, but we also need to look at reimbursement rates, and that's for all levels. We also need to look at provisional licensure. What is that? How can we get reimbursed on individuals that are in training, reimbursed and not at that licensure level? And we've done a little bit with peer recovery specialist, which is a sub-baccalaureate degree that we do get reimbursed through Medicaid, and looking at what are some other kind of assistance. We have physical therapy assistants, occupational therapists, but what kind of mental health, specifically behavioral health assistance that we can provide to provide extra care. And the last R, so we have routes, resources, is regulation, policy. Kind of what we heard from Hannah about action is looking at licensure requirements. We have minimum requirements in some fields, but then we learned that our universities, they like students to go extra long, take more hours and credits, especially at a graduate level, because then they can have a premium on tuition. So having those conversations, like it's not about you, universities, it's really about making sure that we have more access to healthcare and making sure our students can get through this highway. Reciprocity, again, with a high military presence, making sure anyone who moves to Virginia can move right into a healthcare system or practice, scope of practice that we heard before, and then thinking about any type of provisional license. We do have requirements, especially with background checks and this and that, but thinking about flexibilities of it in experience gain to work towards licensure. So those are some of the things that we are working on.
That's terrific. Thank you so much. And I love the way these presentations have complemented one another. We have in our Q&A, really it's a political economy question. And I wonder, Sarah, if you want to help us talk about, given the many benefits of full scope of practice for NPs, why do some states still have the restrictive scope of practice laws? And do you see any variation in those laws in rural areas?
Okay, yeah.
Exceptions?
Good question. Wait, you can hear me, right?
Yes.
Okay, good. So in terms of the why, that's the $100,000 question right there. These are legislative battles. It's arguments about quality. Some of it is about donations, political donations. Who is better funded, who can tell the better stories. I will say that a lot of the research, especially about quality, goes back quite a few years. But recently, the economists have really adopted some of the empirical estimations to give you, high quality evidence of causal type of estimates. And so I'm hoping that those will make their way into the state legislatures and just illuminate what we know and what we don't know. For example, I have a new paper, it's not even public yet, but it actually shows a benefit to the physicians of transitioning to full practice authority in that their malpractice cases against them go down. And it's because you actually sever the ties with the nurses. And so when there's oversight, the physicians can be sued for something that the nurse does. And when you sever that, the physicians are no longer liable. So this is a benefit, and this is a kind of information that could help move towards full practice authority.
Got it. And then broadening this question a little bit, because it was, Cynthia, you mentioned the 504 status. What kinds of things is your coalition seeking to advocate for? And is it Tennessee? Is it Virginia? Sort of where are you, generally, how are you thinking about your policy advocacy strategy?
Some of the things that Megan mentioned about provisional licensure and things like that, those are some of the early low-hanging fruit things that we are advocating for in this early stage of things. Taking the regional approach, we're doing a localized inventory of all of the courses and all of the programming that exists. And to answer your question more specifically, once we get that gap analysis finished in September or October, we'll be strategizing on what our longer term policy requests would be.
Great. And Megan, in your experience, Virginia sort of evolved in its scope of practice, for example, and with respect to the advanced practice nurses, how does it look across behavioral health and some other areas where there have been historic shortages? Is there something that happened in the one subsector of healthcare workforce that did or didn't happen in another, or was it more of a wave in Virginia?
I think it was more of a wave in Virginia. So it really, to get to the point we are now, there was a lot of politics. That was a great question. The difference between our medical society as well, understanding. But I think we're at a better place that we know that we just need more bodies, people serving if we want to increase quality access to healthcare. So I think that also supports the effort of what the changes in scope of practice and how we view our workforce and our licensure requirements.
Terrific. And then Hannah, you mentioned telehealth. What kinds of policies are states contemplating in telehealth that are not going to just rearrange deck chairs, right? That may actually make a difference in the overall availability of workforce?
So I can speak specifically to Indiana, who has had historically a telehealth certification. And that, I don't know that it's a policy facilitator necessarily, but it was a way of basically monitoring and tracking those professionals that were geographically located outside of the state and yet providing services through telecommunication means. After COVID, that kind of completely changed the game. And so I think states are looking towards other types of policies to facilitate telehealth and the expansion of telehealth. So I think that what we're seeing with the uptake in compacts, interstate licensure compacts, that telehealth is a major, I guess, it's given major incentive to states to look at these interstate licensure compacts for some professions, specifically to facilitate telehealth provision of care. So definitely, I think the compacts and hopefully antiquated policies where we have like dual regulation for individuals, we'll see that kind of maybe trickle away.
Excellent, thanks. And we also had a question. I wonder, Megan, if you could help address this one. What are some of the Medicaid policies? There's reimbursement rates, of course. There's but what other kinds of Medicaid, when you turn to DMAS, as we call our Medicaid agency, what kinds of things were you hoping to achieve there that might help boost workforce?
I think definitely the reimbursement rates are really important if we're going to get people to these tough and challenging jobs. The other is, what do they reimburse? So not even the rate itself, but like community health workers, example, a lot of states reimburse there. Virginia is slow to that, thinking about it, or what actually has to be licensed or certified. So that's the first step, is to get someone certified. What does that mean? And then make sure that when we're using those, and we know community health workers, not just great for our communities, but for individuals that need to step into the workforce and gain that experience. We already did a step with the peer recovery specialist. So I think that's a great example. And the other things is around something that's dear to my heart is around in Virginia, that we have kind of very vague language around background and criminal records and what that means. And so thinking about peer recovery specialist is a great example of that. Someone who has had a substance use issue is a great peer recovery specialist, and it helps get them in the workforce. And so other regulations on who and what background is needed to do some of these jobs is also important work that there's been a lot of conversation around.
Thank you. And you've all mentioned, of course, in the context of COVID and burnout, and we do hear in the medical journals about physician burnout, but the burnout in other types of professions within the healthcare workforce has also been really important. And there's this kind of this fear that the burnout has led to lower employment. Sarah, can you say something about the numbers of, for example, nurses or advanced practice nurses at the moment?
Yeah, I actually just looked this up the other day. So the BLS has numbers, actually just their latest ones are for 2021, so I can't speak to this year, but surprisingly, they're actually up. So we see from 20 to 21, RNs are up about 2% and NPs are up about 11%. And this was actually faster growth than from 19 to 20, where the NPs were up about 5%. So
interesting. So
yeah,
there's maybe a struggle hiring them, but something in that has worked to bring them back into employment through this crisis. It feels like. If we can
and
speculate.
enrollment in the schools are also rising. So I guess your question's about the retirement end. I don't know if maybe perhaps one of the other speakers knows.
Are we seeing earlier retirement? It's encouraging that we see employment up. I mean, if you think about the burnout, you would have thought, wow, there's been a reduction, but it sounds like numbers are up. Hannah, any thoughts on what the retirement looks like?
So I can tell you, based on the data that we track here in Indiana, which all of our licensed health professions report every 2 years it's required as part of their continued licensure with the state on their anticipated employment plans for the next 24 months. We saw a slight increase in the percentage of registered nurses that reported that they intended to retire within the next 24 months. And we did see a slightly greater number of nurses within the, I think it's 60 to 65-year-old cohort that went into retirement status. That being said, our pipeline has increased, as many states have done through educational initiatives, funneling money into especially, I think, ASN programs to very rapidly address the nursing shortages. And so we're seeing this, I guess, rapid surge growth in our registered nurses. So we're anticipating a backfill probably within the
Terrific.
next several years.
That's wonderful. Well, certainly, hopefully, Cynthia, in your wonderful coalition work, this will bear out. I want to thank all of our panelists for joining us today and for a really interesting set of presentations and discussion on this important topic. And we have in 2 weeks our final session for the summer on policies to promote efficiency, reduce surprises, and elevate transparency. Will be on Wednesday, July 27th from 1 to 2. Thank you again, everyone.